So I was going to stop. I have more slides on different treatments, but I thought maybe the bulk of the time we'll take questions and back and forth, if possible. Maybe, but we don't have the sheets, but maybe we can start out with some questions. Popeye.
Yes, if a person jogs regularly throughout their life, are they more or less likely to develop arthritis?
Okay, that's a great.
Why don't you repeat it?
Yeah. Okay. If a person jogs regularly most of their life, are they more or less likely to develop arthritis? In general, less. In general, the benefits of the jogging outweigh the pounding on that joint. There's lots of studies looking at exercise triggering arthritis. So our usual amateur athletes, we're okay. The professional athletes, the studies have shown they're at higher risk. So the football players, you know for sure, yeah, they're at risk. Soccer players are at risk. We're doing a study on soccer players, not just professionals, but kids playing soccer. Are they more at risk of getting knee osteoarthritis later? So our regular exercise, no. But of course, if you wipe out and you injure yourself right through a joint, then that joint may get more osteoarthritis. And just a corollary to that question, occupations, there have been no specific occupations that have really increased the risk of osteoarthritis except farmers. And I wonder why, and then there's some theories that, well, in most other occupations, if your knees are sore, you slow down a bit. But a farmer maybe you got to milk that cow, you got to bring in the hay, you can't really slow down even if you want to. So we don't know why, but it seems like farming is the occupation that really you get more osteoarthritis of your hips and knees. Yes? So the comment is, there was an article about, really don't rush into joint replacement surgery unless you really need it. And I would agree with that. And most surgeons we have here would not operate on you unless you're really ready. So I think we're lucky we've got excellent orthopedic surgeons here. And so some people think, well, maybe I'll just go to the surgeon and just get in line. But you don't have to do that anymore. We do have spaces. And even if you go just to get in the queue and you don't need to, you're going to wait 2 years. But if you go right when you need to, you'll wait 6 weeks. So it's okay. They will triage you based on when you're ready and your pain levels and your function. In general, the surgeons are simple folks, and they have three.
This is being broadcast.
Yeah, I know. They have three good ways to decide whether you need surgery to replace joint. And if you can walk a couple of blocks, if you can't walk more than a couple of blocks without significant pain, 1 or 2 flights of stairs, or if pain wakes you up at night regularly. If those 3 things are happening, then you may be ready at that point. And everyone's a little different, so but those are what their criteria are. Yes? So the question is, in fingers locking up, is that a form of arthritis or not? Usually, we have 2 different kinds. Who here's had a trigger finger? Ever had one of those? Yeah, so what happens with that? It gets stuck. Yeah, so that's a classic locking of a trigger finger. And yeah, so it could be a trigger finger and it gets stuck down. You have to go open it up with the other hand. Hurts. And that's tendon nodules that can do that. And that's one way the hands lock up. If the hand is cramping and crossing over, there's certain blood chemical abnormalities that can do that, like stuff that you deal with more, like low calcium,
low
magnesium.
potassium.
Yeah, so that's a separate thing. But if your finger's stuck down and you have to open it up, that's a trigger finger. If it's cramping and crossing over like that, it could be a disturbance of your electrolytes, maybe related to medicines or other things. Yes. Yeah, so that's in one of the, I couldn't mention them all. There's over 120 kinds. That one is about 1 in 200,000 people. And that one, The question is polymyositis, which is a type of autoimmune disease. I see it, a lot of rheumatologists see it, neurologists can see it. Who's your doctor? Kessler. Oh, neurologist? Kelsall. Oh, right in here. Oh, yes, good, yes. So, we use the same medicines as we do for rheumatoid arthritis, basically. And that is a nicely treated condition, polymyositis. But it is a type of autoimmune disease. Here and then, oh yes, platelet-rich plasma. Okay, what are the other two? So the question is one, platelet-rich plasma. What's the other one?
Stem cells.
Stem cells. Okay. What's the third one?
And the third one is
Yttrium.
Yes.
Okay. So the question about these three therapies. Let's start with the last one first. Yttrium is a radioactive material that I don't do it very often now, but we would inject into very inflamed joints, and it basically kills that capsule around the joint that's inflamed. It goes about a few millimeters into that capsule and kills off the cells and reduces the inflammation. As you can imagine, it's a radiation therapy really, and and this thing, it grows back. So before we had these fancy new medicines, in some people with one bad joint, we would inject, typically the knee, we would inject it with yttrium. We still do that. In Lionsgate, there's a doctor that still does it for us, but it's usually one bad joint. If you've got 20 joints, you're not going to inject them all with yttrium. Okay, that's one. Stem cells. So, and yttrium lasts a few months. Yeah. Stem cells, there's a lot of promise in stem cells for various diseases. It hasn't really panned out yet for osteoarthritis. What we do, what some of the surgeons do, I wish I had a black, oh, I do have a.
I don't know if you have chalk though.
Chalk, okay. And can I write on this thing?
Yeah.
With this? I'm not going to ruin it?
Try.
Okay. So, if I draw a joint with the cartilage. So that's cartilage. If you've got a big divot taken out of your joint, like from an injury, there's a hole here. We can take some either stem cells grown into cartilage, or even better, you take a piece of this stuff here that you don't even need because it doesn't touch the joint. You cut it out, take out the same shape of this, cut this out, and you stick it into that. Put it in and let it grow and cover it up. And that actually works quite nicely. The problem is most people here don't have that divot. They've got just, the whole thing is narrowed. So, and when the whole thing is narrowed, even you can't take stem cells and replace it all right now. Well, the surgeon, oh, here's the capsule, by the way. Here's the covering where the fluid is. The surgeon will go in and clean it out. Do you remember, has anyone ever had that? They go in with an arthroscopy and clean out the joint, try to smooth it out. Sounded good, but recent studies have shown that that doesn't seem to give very long-lasting results. And exercise, that's why I was pushing exercise. Exercise actually does better than cleaning that out and leveling it. Because I think there's more to just that rough cartilage, I think we realize. And the last question was platelet-rich plasma. So I have a friend who has lots of money, and he went to Germany to get the platelet-rich plasma. And what they do is they take out his own platelets, they give it some, they spin it, yes, and they do some treatments to it. Then they inject it back in, and then it creates something in the platelets, I don't remember what it was, helps to create, helps to heal parts of the body. So this guy had it in his shoulder tendons, and he said it felt better. So anyway, so then this German doctor that was doing it, orthopedic surgeon, came out here, and I invited him to our research group, and I said, let's hear the research. He was actually quite eloquent and showed a lot of good science behind it. But what's missing was the clinical evidence. He couldn't show me 100 patients where you treated 50 with this and treated 50 with a fake and see if there was a difference. He said, it's coming. And I told him, we'll help you with that study if you want. So we're in discussion. So interesting stuff. People are getting it, but the proof isn't there yet.
I'm on the list.
Okay. Okay. If you want to do the study. Yes?
Can you comment on the antimalarial plaquin that does?
Plaquin.
Yes. So Plaquenil is one of my favorites. Yes, antimalarials is one of my favorites for mild to rheumatoid arthritis, lupus. It works really well, and it's good in combination. So, and it's very, very safe. Some people get a rash, and in here we wrote it could cause, rarely it could deposit in the back of the eye. About 1 in 5,000 to 1 in 50,000 people, slowly, but we would, of course, monitor with eye tests once a year. It works very well, and one interesting thing about hydroxychloroquine or Plaquenil is that it has a big benefit on the cardiac status of people with rheumatoid arthritis and lupus. So people with lupus, it's very, very... What condition were you asking about?
I don't know.
Okay, so it's one of those ones we use if we're not sure if it's rheumatoid or lupus yet, because it works for both. So if you don't have one, it's a mild pill, and it does have some long-term benefits. Yes?
You mentioned osteo doesn't go to the wrists.
Correct.
So if on an X-ray it showed there was arthritis on the wrist, what does that mean?
So I wonder if sometimes...
Repeat the question.
Yeah, thank you. I said osteoarthritis doesn't go to the wrist. If the X-ray shows arthritis in the wrist, what does that mean then? Well, a couple of things. When I say it goes to the base of the thumb, sometimes they call that the wrist. But I know it's not the wrist, it's the thumb. But this is the wrist. But if they, so maybe that's what they meant. Okay? Maybe it is the wrist. It's at base of the thumb, not the wrist. The other thing is maybe there was a fracture of the wrist. Maybe there was an injury and it's post-injury osteoarthritis. Or maybe there's another type of arthritis, like psoriasis-related arthritis, which can go to the wrist. Or calcium crystals, which can cause arthritis in the wrist. Especially in older women, they get calcium crystals in the wrist. So that's a good question. Is the wrist sore? Yeah, then with this or with this? Okay, so that should be looked at then to figure out what's going on. Yes?
You mentioned the osteoarthritis. I was used to hear that. Now they say it might be psoriatic
Arthritis.
So, yes?
What is the difference?
So what's psoriatic arthritis? I think that is a good question. Okay, how do I answer this? There's a type of arthritis called psoriatic arthritis that what typically happens is you get psoriasis, which is a rash on the elbows or knees. It could be in funny little areas that you don't even notice. In the scalp, around the belly button, and in the crack of the bum. You could get a little rash there. You don't even know. Maybe it's just itchy or something. And then 5 or 10 years later, you can get a swollen knee or an elbow or a toe, and that's called psoriatic arthritis. It happens, so lots of people have psoriasis. About 10% of them will get the arthritis associated with it. And we treat it similarly to rheumatoid. It's not as severe as rheumatoid, but we treat it in a similar way. And there's cousins to psoriatic arthritis. There's 4 diseases. There's psoriatic arthritis that we talked about, and ankylosing spondylitis. Infection, reactive arthritis, infection-triggered arthritis, and Crohn's disease, which can cause an arthritis. And sometimes you can get overlap. So the people with psoriatic arthritis may have a family member with Crohn's disease, or may have a family member with ankylosing spondylitis, which is a disease of the spine. You get stiff spine, doesn't move very well. Yes?
Well, after the infection,
Pardon me?
can you treat the infection?
For these,
Yeah, well, just for any, you mentioned it in other forms of rheumatoid too.
so can you treat the infection? For example, I mentioned that infections can trigger rheumatoid arthritis. So what about just treating the infection? By the time they get the arthritis, the infection, so many studies have been done looking for the infection that could be the trigger. There are lots of theories. Most of them haven't panned out. And we think that the infection may be a virus, and it may have been a long time before the rheumatoid arthritis started. So when we don't really treat the viral infections with antibiotics, we have antivirals, but we don't really find the virus right now when they get the arthritis. These people yes, we can treat the infection. The infections that cause this type of arthritis are the things you can get, the diarrheal illnesses like Salmonella, Shigella, Campylobacter, and Yersinia. Those are 4 bacteria that give bloody diarrhea. And then, so typically what happens is there's a military base. The cook doesn't cook something really well. Everyone gets Salmonella. 200 men all get Salmonella. It's not pretty. But 10 of them get arthritis afterwards. 10 of them. And they often have this gene called HLA-B27. And they get this. And so we treat the Salmonella, this typically goes away. And there's one other infection, chlamydia, which is a sexually transmitted infection. And that can cause reactive arthritis. So if a 20-year-old university student comes to me with a big knee and a big ankle, we talk about their possibility they might have a sexually transmitted infection. They wonder, why am I asking about that? But and I explain that this could be the trigger. And we treat the chlamydia, and this gets better. So yes, we can treat some, but for rheumatoid, it doesn't seem to work. Though there are some alternative practitioners that say that they treat rheumatoid arthritis with antibiotics. You may have heard of that. Typically, those are tetracycline antibiotics. And yes, patients do get better temporarily with the tetracycline antibiotics, but it's not because it treats the infection. Those antibiotics also suppress the immune system, because as soon as you stop them, the rheumatoid gets worse again, not like one of these where you treat the infection and it goes away.
There's a question.
Yes, and then we'll go there. Go ahead.
Once you're on methotrexate, are you on it for life?
Once you're on methotrexate, are you on it for life? The answer is probably not, because probably there's going to be something else. You can try coming off, or if it stops working, you can try something else. We've looked at studies where you think, well, you start 100 people on methotrexate, 10 years later, how many of them are still on it? About 50%. Some of them it didn't work anymore, stopped working. Some of them they got better, and some of them they needed something else. Some of them, no, it doesn't include the ones that died, your friend. Back there.
How often do you see young kids age 15 or so with rheumatoid arthritis?
How often do we see young kids age 15 with rheumatoid arthritis? It's less common than the 20 to 50-year-olds, but it's there. We have a whole team we have 7 pediatric rheumatologists in BC that see those kids. And we do see it, and we treat it very similarly to adults. So we do see it. And I get them when they graduate and they come over to me, and they're usually under good control. And often, the nice thing about the teens and the kids, once they go into remission, it may not come back. It may come back in 10 years, 20 years, or may not come back at all. Same treatments. And just one point about the kids. We use so methotrexate for kids works really well, and the worst thing for kids with arthritis is steroids because it keeps them small. It doesn't let them grow, and so methotrexate has been a huge help, and then the biologics have been an amazing thing for kids. Keeps them in school, and they play sports, and they get their limbs growing properly. It's great. Right here, and then we'll go in here.
My wife here, either she's in pain or in agony, but she's got fibromyalgia.
Fibromyalgia, is it part of the arthritis too, I guess, eh? Is it from the rheumatoid?
So
Fibromyalgia.
fibromyalgia, the question is what type of arthritis? Remember at the beginning I said, we can talk, rheumatism can affect the soft tissues, the muscles, and the tendons. So fibromyalgia, or let's call it fibromyalgia syndrome, FMS we say, affects the soft tissues and muscles. So the joints are usually okay, and it can be very painful. We don't really know a lot about it. And we just developed Canadian criteria in 2012 to look at it, and it's really pain around the body, fatigue, and sleep disturbance. And we don't have good answers for it, but the things we do know that help this are exercise and addressing the sleep issues. But yeah, it's a type of rheumatism, I guess you would call it. I'm just going to come down here to right here. Hi.
I have AS and I have had it for over 30 years. And my question is that I'm taking the anti-inflammatories, is there the side effects from taking it so many years? I'm worried about it.
So the ankylosing spondylitis, or AS, that's the condition. It can affect the spine, sometimes eyes, occasionally, sometimes the peripheral joints too. And the question is about anti-inflammatories. They work really well for ankylosing spondylitis, but again, for all of us, the side effects are worrisome. And every little once in a while in the news, you hear another story about anti-inflammatory side effects. The most recent one came from Europe. No, actually, it was from Toronto. And it was about diclofenac. Did you read that one? So what anti-inflammatory are you on? Celebrex. Okay. So diclofenac, or Voltaren, or Arthritis, was recently implicated in increasing heart risks by, I think, 1.6. 1.6. So if 1 is normal, so 1.6. So slight increase, and I think it's more significant if you're already at some risk. So if you have diabetes, or if you have had heart issues before, then I think it may be more risky. Most patients with ankylosing spondylitis are younger and generally in good health and can tolerate the anti-inflammatories. There was one study of Celebrex for ankylosing spondylitis that actually showed, it was the only study of an anti-inflammatory that showed that it reduced the progression of ankylosing spondylitis. So I say I wouldn't have picked you as having ankylosing spondylitis, but so it does slow down the progression. So if you don't have a lot of heart risks and your kidneys are working okay and your blood pressure is okay, then I would be pretty happy with continuing the Celebrex on a regular basis. I don't know about, what would you say about?
I agree with you.
So the other, so you could stop, no problem. See how you do, and if you're not feeling good, go back on it. I'm a big believer in trying it out, especially for anti-inflammatories. They work pretty quick. So if you stop it, you're going to know in a week whether you need it or not. Whereas those other drugs we were talking about, like methotrexate, are slow. You don't stop and start because you can't tell. But Celebrex, you can always stop and start. Okay. Can I talk about osteoarthritis? Okay. You know what I didn't do a lot of is talk about the drug treatments for osteoarthritis, right? Is that what you want me to do? Okay, all right. Do you want me to talk about osteoarthritis? Ask me a question about it, and I'll talk about it. Just give,
How come so many people have osteoarthritis? 50% compared to 2%?
okay, why do 50% of us have osteoarthritis? I don't know.
We're getting bigger.
Part of it is we are getting a little bigger. Dr. Palpu said that. And it's true. So knee and hips.
And we're living longer.
Yes.
So it's a combination. We're heavier, we're older. That's probably the biggest reason. Looking back in time, people didn't live as long, and we didn't have such calorie-rich food in high-income countries, right?
And the other thing is, and it's inherited. So if you've got, there's different types. There's the nodal osteoarthritis that, if you get it, the bumps on the fingers, that's very inherited. So you could often blame your mom. It's often mom to daughter for the nodal osteoarthritis, the bumps, and then knees. And it's really, this is the joint, this is the knee. Okay, so you've got this lovely, nice cartilage here. So you tell me what would cause this to become damaged? Sport. Okay, so we talked about extra weight, so extra force going down here. So if you're 30 pounds overweight, that's a lot of force across this knee extra. If you've ever gone camping with a backpack, 30 pounds, your knees are sore after that. So weight, trauma to this knee. So bashing it in a way that's not supposed to go and having this part take out a divot here and having this divot erode off and sort of bits will start breaking off over time. So that's another reason why we get it. How about all these great muscles that we have to support the joint? And if those are weak, this joint gets a little floppy. There's sideways movement here, shearing off extra cartilage. So weight, weakness, inherited, trauma, and some rare things that so the bones are not that hard actually, they're soft. Think of a chicken bone, you can bend into it, press into it. So if you have thin bones or osteoporosis, you actually have less osteoarthritis.
Well, it's just like I used to do a lot of walking, and then I would walk, then I would jog, then when I get tired, my knees is just...
So we're talking about exercise, yes. So walking and jogging are great for your legs, but if you do too much, you're going to get sore. You have to pace it. And while weight-bearing exercise is really good for your bones, you actually need to do other strengthening for your muscles. So those pamphlets out there are very good. There's some exercises you could do to strengthen your legs that have nothing to do with injuring your knees. Leg raises, I call them the side series. You lie on your side and you lift up your legs. Strengthen out your bum muscles. Partial squats. Anyway, there's a whole good list of pamphlets.
What about bicycle riding though?
Bicycle riding.
Because I'm a basketball player and I have bad knees. Is there something called a meniscus in your knee?
Is there something called a meniscus in the knee? I didn't draw it in here. These are little, get another color. These are little triangle shock absorbers here on both sides of the knee. And if you look on top, they're little discs, like little washers that are in your knee that are soft and spongy. And of course, trauma, they're really good to protect your knee. You basketball players, with all that pivoting and twisting, can tear these. Also, with time, they could extrude a bit, push out so that they're not actually doing their job. And then that's going to cause more osteoarthritis again from trauma. But your question about bicycle riding it's great. Stationary bike to start with, low tension, intervals, and then as you get better, increase up the tension, go to a spin class. Those are really great for your knees and for your cardio fitness.
My knee is more stiff in the middle of the night than any time during the day.
So the knee is so that's going to be a common issue, nighttime knee pain and stiffness. If you can tolerate the anti-inflammatory, you might take it at bedtime or with dinner, and that might tide you over at night. That's a temporary Band-Aid solution, but strengthening up the leg in a good way will reduce the nighttime pain. But if it keeps going and your x-ray shows that it's really narrowed,
Good evening, visitors. It is now after 8 p.m. and visiting hours have ended for the evening. Thank you.
so if your night pain, and this, remember I said you can't walk a couple of flights of stairs and you can't walk a few blocks, and your x-ray shows that the cartilage is gone, then it's time for a new knee. And you'll be out, not playing basketball, but you'll be golfing and other things. And just good point with swimming, and you don't have to swim to enjoy the water. There's a water exercise classes that you could stand up. The Aquasize class, the Arthritis Society has Aquasize still and land classes that you stand in the water. You have just 20 pounds on your legs, and you could do a lot of great strengthening in the water. So I'm just trying to talk about osteoarthritis. What other questions about osteoarthritis do you have? Yes?
So during the day, I rarely have knee pain, although I have arthritis in my knee. At night, I sleep with a pillow between my knees because the weight of my knee hurts it. So why would I have pain in the middle of the night rolling over? Rolling over in bed, my knee hurts, weeks in. Why does that happen?
Okay, so the question is, daytime you can handle it, nighttime you need to put something between your knees or rolling over pain. So I'm going to have another color. I keep adding to my picture because there's other structures in the knee that cause pain because your cartilage, doesn't actually have pain fibers. It's the bone underneath. If you've put a lot of pressure on your knee, and this goes for you too, if you put a lot of pressure on your knee during the day, you can get a little bit of areas of bone inflammation or bone edema, and you don't notice it, but that night you go to bed, these little areas can throb. Okay, so it may be some of what you've been doing that day. The other thing we have connecting our knees together are these ligaments. And you could get pain from the ligaments when you're rolling over in bed at night, the legs up at the side. You can get ligament strain, and where they insert here, you may have strained it during the day, so you have pain coming here and here. And that actually, and there's one more area in the knee, on the inside of the knee, and you can actually feel, if your knee is bent, just on the inside of the knee, below the knee on the flat part, you press on there and it hurts. That could be bursitis, more common in women, and it's on the inside of the knee. That could hurt at night, and your knees touch together, that could hurt your bursitis. More common in people with osteoarthritis of the knee. So my mother-in-law has osteoarthritis, had, because she had her knees replaced. But before she had her knees replaced, she was always complaining of knee pain, and I wasn't paying that much attention. And one day I went to examine her knee, and I pressed on her knee, and it wasn't sore, and I pressed down past her knee, and she jumped because she had bursitis. You're not supposed to treat your family, right? But anyway, I took some steroids home, and I injected her knee, and she said, wow, I injected this part here. And she said, wow, that really felt good for about a month or so, but then it came back. Yes? Back, yeah.
I wonder if you can talk about the connection between osteoporosis and pain and osteoarthritis and fatigue and pain.
That's a good point. Osteoarthritis and pain and fatigue. Because it makes sense you can have pain in your knee when you have osteoarthritis, but you can also, when you have a pain problem that limits sleep, like you were saying, our sleep is very important. And we have this cycle of sleep where we have light sleep and deep sleep, and we cycle back up to light and deep and all through the night. But if you've got pain waking you up at night and interrupting that deep sleep, you may think you've been sleeping for 8 hours, but in fact you haven't had a good restful sleep because the pain's been interrupting it. So you may end up after a while waking up fatigued and pain in other areas because when you don't have a good night's sleep, you can get muscle aches and pains too. So I think, is that what you mean? Because there's that connection between one joint pain, night pain, and sleep disturbance and daytime fatigue. That's my connection. What are you thinking?
I'm thinking also about then the connection to things like depression.
Yes, that's actually a big part of what, if I take another picture here, this is the picture I draw, and it's similar, it helps with fibromyalgia, because if you have pain of any cause and sleep disturbance, fatigue. Oh, sorry, this is my scroll. Oh, okay. Actually, I'll draw it better here and higher. So if we have pain, sleep disturbance, fatigue, and we can see a circle coming, and maybe reduced exercise because you're not exercising as much. You can throw in deconditioning. Makes the pain worse. The cycle continues, and what naturally happens is there's symptoms of depression start to come through here in this vicious cycle. And it's very, very common. So I can end up seeing someone that's been cycling through here for months and years. They come to me, they've been put on antidepressants, they're on sleeping pills, they got heavy because they're fatigued and not exercising, and they want to treat this. And I say, well, yes, pills are not going to, pain pills are not going to be the answer, the only answer. We need to deal with all of these things. So we have a multidisciplinary or multimodal approach to this person, and you could put lots of conditions in here. And I know, Anita, you probably deal with people in this cycle as well. It's hard, and we need the help of family. We need the help of physical therapists, psychologists, and sometimes we use pain clinics to help break out of this cycle. Yes?
I want to know what treatments you do recommend for osteoarthritis in the hand, and do any natural remedies help, like glucosamine?
Okay, I wanted to talk about that. The end of your question was diagnosis, why it happens, and now treatment of osteoarthritis. Okay, all right. So, in rheumatoid arthritis, I told you we had medicines that can slow down the progression. We don't yet have that for osteoarthritis. Do not have it yet that we know of. And there are some interesting treatments out there. There's one, called strontium, which is not even, have you heard? It's not even a patented drug. But there's some very interesting new ideas about strontium as slowing down osteoarthritis. So stay tuned. It's not really available here. And maybe that will be one. But in the meantime, while we're waiting for that disease-modifying drug, we use simple things like heat and cold. If you go to London Drugs, you can get the wax. Have you ever guys seen those? Wax baths, and then alternate in the cold. And the therapists do that at the arthritis center, and it does give temporary improvement in some of the symptoms. We use acetaminophen or Tylenol, which can take the pain from a 5 out of 10 to a 3 out of 10. It does do something. We use anti-inflammatories for osteoarthritis pain. Okay, we'll come there. Anti-inflammatories, and that's about it for now. Glucosamine and chondroitin sulfate have been studied for osteoarthritis. There's 4 big studies 4 big studies looking at osteoarthritis, but they were all of the knee. And 2 of the studies showed benefit and 2 didn't. There was a big New England Journal of Medicine, the GATE study, that showed that glucosamine sulfate with chondroitin sulfate, I think, was as good as Celebrex for osteoarthritis of the knee and probably had less side effects. We did a glucosamine study here in Vancouver that showed no benefit. It was a backward study. We took people that said they did really well on glucosamine and they're on it already. Okay, so we took, if half of you said, I'm on glucosamine, I love it, it helps me. So we'd take you into the study and we'd give you either more glucosamine or a placebo. And we wouldn't tell you what you were on, and there was no difference in stopping the glucosamine or not. So it was a backward study. So, so for hand, I don't know if it works. I tell my patients, try it for 3 months. The problem is you have to take 500 milligrams 3 times a day. And try getting someone to take a pill once a day. 3 times a day is hard to do. You had a comment.
Well, actually, is there any improvement with magnetic treatment?
Okay, magnet. So we'll talk about that. And I was just thinking, as you were saying that, the other thing for osteoarthritis of the hand, if you have 1 or 2 really sore joints, so we can inject them. And that sometimes gives temporary or even several months of relief. Magnet treatment has never been really shown to be a benefit. And I have lots of patients that say, I got this bracelet, my friend gave me this bracelet, I felt stupid putting it on, but it seems to help, and I'm just like, no problem, carry on. So I don't have a problem with it. But the studies aren't really there. Same with a copper bracelet. I've been telling the Arthritis Society they should get copper bracelets and give to the Arthritis Society on them, but they didn't do it. But magnet therapy has not been shown to be a benefit.
I use also, I get injections with Arthritis.
Oh, okay, thank you.
Yesterday, today.
Orthovisc injections. So moving away from treatment of hand arthritis, knee arthritis, there are these things called this viscosupplementation, or orthovisc, or neovisc, or synvisc, and that stuff you might like too. You inject it into this sac of fluid. It's a little vial, and it's hyaluronan. It's a protein that's normally found in joints, and it's really thick like engine oil, but it's the normal stuff and it's clear, and it's what protects our joints and gives it lubrication. And in people with osteoarthritis, if you actually, as I do, take out the joint fluid, it's too watery. It's not working very well. So it's like giving them an oil change, right? You just had an oil change. Yes, you get 3 injections, or you could have 1. It can last for about 6 months, and some studies have shown this is beneficial. Now, this big group called the Cochrane Collaboration did an analysis of all the viscosupplementation studies and put the data together to see if it worked, and they weren't very impressed with the long-term results. I don't think it slows down the progression, but I do have some patients that come in and they ask me to do the shot. I do it to them, and then they go. I have one patient that ran with the torch, and because she got her injection, and then she still does half marathons. She comes in every once in a while getting her injection, and she seems to do well. I have a few others that do well, and some that don't do so well. The problem is it costs how much?
Around $800.
$800 for 2 knees, so $400 per knee, and it can last for about 6 months. And if you think the Celebrex costs about that for 6 months, not all in a row, so it might be worth a try if it's your knee. It doesn't work in other joints, so people have done it for hips as well.
What is it called again?
This one was called Orthovisc, but if you talk to the pharmacist, they'll all know what they'll all know. There's Synvisc. Your doctor has to do it. You go buy it, you bring it back, and we do it. It's made out of rooster's combs. Just so you know. You're allergic
if you're vegan, you may not.
Yeah, vegans. Right here. Prolia?
Yeah, prolia.
Prolia, no, that's for osteoporosis. And that's not this stuff.
Oh, but does it do the same thing?
No, that's for osteoporosis or thin bones, not osteoarthritis.
Oh, I see.
That's a whole different talk.
You only have it twice a year, though.
That's twice a year, yes.
Then I need it.
But this is that. But that doesn't help joints.
Oh, it does?
That prevents fractures. Yeah. Yes.
What about a product on the market that's been for a couple of years, people swear by athletes take it for joint pain,
Yeah. You know what? I have a conflict of interest because I know the owner of the company that makes that.
What is it?
Sericil. Okay. Can I talk about it? I know the.
Well, just say you have a conflict.
I have a conflict of interest. I work out with the guy that owns a company that makes it. He's a very famous guy, a very famous family here, and they own a lot of. No, forestry, and they own this slag heap, and they thought, I got to do something with the stuff in the slag heap, and basically it's a bunch of minerals, and they say it works, but it hasn't been shown to be a benefit.
They say you take it according to your weight. They say
Yeah.
I'm just wondering if you have.
There's not any studies.
Yeah.
It's not been well studied.
But it's people say, the problem is I hear lots of stuff, and a lot of people say this works or that works. I just want to see the research, and then I'll be a big proponent of it. Like glucosamine, I wasn't so sure. I saw a couple of good studies. I said, okay, maybe. But I want to see the studies in people, double-blind, give them the stuff, or give them a placebo, and let's see what happens long-term. I think that's what I need to see, because anyone can say this stuff, any athlete can get up there, or any sports announcer will say, I tried this other stuff and it helped my cold,
Right.
and I need to see the study.
There's a question way up there. It's been asked. The man.
Yes?
What are your thoughts on the notion that anti-inflammatories damage cartilage and make arthritis worse?
So repeat it.
What are my thoughts on the notion that anti-inflammatories make arthritis worse because they damage cartilage? So my thoughts are that may be true because rat studies have shown, and this is back in the 80s, some rat studies have shown that if you give rats anti-inflammatories and make them run on their treadmills, they actually had more knee damage. It hasn't seemed to, we're not rats, we have different cartilage than rats. It's interesting. I'm not a big fan of regular anti-inflammatories for osteoarthritis for a number of reasons, just because of side effects and because it's not fixing the problem and because maybe what you say might be true, but the big studies have not shown it. And the big studies looking at like the glucosamine study versus anti-inflammatory didn't show that they got a lot worse on the anti-inflammatories even as their pain got better. So because the anti-inflammatories don't prevent the disease to progress, I don't believe in taking them on a regular basis. Of course, for some conditions like Angst-Bond, where it may slow down the progression, then I do. So you got a good point.
My question is, you were speaking about Voltaren. Was that Voltaren the actual topical that you're talking about that caused the problem?
No, it was the ingestible.
Oh, ingested, not the topical.
Yeah.
Back to the hands. What are your thoughts on, I was told that there was nothing you could do. Eventually, you could either have some kind of implant or you could fuse the joint.
Okay, so back to the hands. We talked about the pill treatments and lack of medicines that slow down the progression of osteoarthritis of the hands. If it gets really bad, you can replace the middle joints of the fingers. It's not a great surgery. Most of us don't recommend it. The surgeons usually don't do it unless it's a really terrible joint. You can. Okay. The thumb surgery, the base of the thumb surgery, is a better surgery. And it's not an implant. They just take they take out the bone that's damaged, toss it, and they take a little tendon, roll it up into a ball and stick it in there, and it acts as a little fulcrum. And that actually can reduce the pain quite a bit. A lot of my patients are very happy about that. So that's for the base of the thumb. For the fingers, there's not much in the way of surgery. You can fuse them. You can fuse this one as well, the base of the thumb. You can fuse this one, and it gives you your grip back, your pinch grip, so that can work. It really depends on your hand surgeon. There's some excellent hand surgeons here and at VGH that do very good jobs, but it depends on you. But there are some surgical options. Yes? The question is about diet and osteoarthritis. I saw a good pamphlet on diet there too, and in the UK, the Arthritis Foundation in the UK has a really good online pamphlet about all the different diets. In short, there's no specific diet for osteoarthritis. There's no anti-inflammatory type of diet that's been shown, though a lot of people will say that what's in fashion now, you guys will tell me what's in fashion now for diet. Okay, Mediterranean, which is a great diet, I think. That's what we try to do. My wife's Greek, though, so I have no choice. But what's in fashion now? Nightshades, okay. Nightshades was in the 90s. I'm talking about...
Gluten-free.
That's right. Yeah, so what's in fashion now is a gluten-free diet with no dairy and no sugar. Okay? So, and I don't think we really need gluten, dairy, or sugar, so I'm okay if people don't want to do that. But I don't think there's any good proof that helps. And we need, our dairy farmers need some.
I couldn't live on that.
Yeah, I couldn't do that. But but that's what's in fashion now. And diet goes through fashions and trends. And I just don't think that that's going to help the arthritis very much. Some of my patients try it, which is okay. And sometimes they say they feel better, but it's pretty hard to change your diet consistently. So that's my impression. For gout, anyone here will admit they have gout? Anyone? For gout, okay, so gout, there's a diet really helps gout. So cutting down the beer, wine is actually okay, and you reduce meat proteins. So that's one type of arthritis that does get affected by diet. So less beer and meat, so two of my favorite food groups, and more wine and vegetables is good for gout. Scotch is neutral, actually. Yeah, so beer is actually the bad thing, and right here.
What about acupuncture?
Okay, so there's another question there too. Acupuncture, there's a lot of good studies that show that it might be, actually the CMAJ, this month or last month?
Yeah, just recently.
Recently had an article about acupuncture, and I don't remember what it was for. I just was skimming, and it showed some benefits. So and especially living on the West Coast, we have a lot of people who have historically been using acupuncture, and they find it beneficial. And I often seem to be co-managing people with an acupuncturist, and I think it works quite nicely. I think you just have to make sure a very good practitioner, clean needles, and that the needles don't go so deep around the joint, because I've had people with the needles actually enter the joint space and it can cause an infection. So keep it in the skin and subcutaneous tissues, and good clean needles, and I don't have a problem with it. There's a question here.
Can methotrexate lead to sleep disorder?
Can methotrexate lead to sleep disorder? Not directly, but sometimes some of my patients say it can cause irritability. And maybe that can lead to the sleep, but it's usually the pain that leads to the sleep disorder. Because we stop the methotrexate, it doesn't seem to change. Yes?
Lower back and osteo?
Lower back and osteoarthritis, treatment or diagnosis? Well, I think the best, so lots of us here, actually most of us here, have had or will have lower back pain related sometimes to osteoarthritis, especially at that lumbosacral junction, just where the spine meets the pelvis. And I think my favorite way to manage and with good success is exercise, is core strength. Strengthen the abdominal muscles, gluteal muscles, and that can reduce the frequency and severity of flares. You're not going to eliminate them completely, but you will reduce the severity and the frequency of the attacks or the flare-ups of back pain. Most of the time it gets better. As you know, it goes like this. You flare up and you get better. There are some, again, the Tylenols and the anti-inflammatories can help for the acute attacks, but my favorite way is to help prevent it by exercise. There are some injections and techniques that people try for people that are very refractory and that get recurrent or constant back pain. And we get mixed results with those. The platelet-rich PRP, there's some experiments going on with that for back pain and injecting that into the ligaments of the spine.
So I'm going to bring the question period to a close because Dr. Shojania has answered questions for an hour, and I'm sure he'll, if you have an extra questions, maybe you can approach him at the end. But I'd like to thank him for such an illustrative talk and answering questions so thoughtfully. So thanks.
Thank you.
And I just wanted to remind you that on May 15th, we have the Let's Talk About Advanced Care Planning. And if you can spread the word, and if you're interested, please do come. Thanks so much.